Hello. It's great to see so many people here to welcome our guest, visitor and Professor Chris Etz, who is visiting us from Rostock, Germany, and he'll be introduced shortly by Professor Lindsay. But I'd like to start by welcoming everyone who's here in person and also everyone who's joining online for this special lecture. This is one of our monthly university rounds series, and this is the Harland Smith lecture. It's an interesting lecture in that it is sponsored by the Division of Anatomy, and many of you may not realize that in addition to the 8 clinical divisions in the Department of Surgery, we also include the Division of Anatomy. So it's an appropriate occasion to note that fact and also recognize the foundational nature of anatomical sciences for all of us as surgeons. We're fortunate to have today the co-chair of the Division of Anatomy with us, and he's going to provide some introductory remarks. So I'd like to welcome Dr. Hong Sun to the podium. Hong.
Yeah, my name is Hong Sun. It's professor and co-chair of anatomy. So we're going to start with the land acknowledgement for today. So we wish to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land for Huron-Verde, the Seneca, and the Mississauga of the Credit. So today, the meeting place still the home of many indigenous people from across Turtle Islands. We are grateful to have the opportunity to work on this land. So about the lectures, the Harland Smith lecture is both Carol Smith and Rita Harland were professor of the Department of Anatomy and for many years. And they share their deep commitment to the University of Toronto and its students. When Department of Anatomy and Cell Biology was incorporated into the Department of Surgery, and as an anatomy division, Dr. Smith donated fund to endorse this lectureship, on which he dedicated to the surgeon whose career have been emphasized on the integration of anatomic knowledge to the surgical practice. So
Thank you, Hong. And now to introduce our esteemed visiting professor, another esteemed professor, not visiting, my good colleague, Tom Lindsay.
Okay, thank you very much, Carol. It's my pleasure to introduce Dr. Christian Etz as the Harland Smith Lecturer for 2026. When we were conceiving how to bridge anatomy and surgery for this lecture, I thought that linking new anatomic concepts to a devastating clinical surgical problem was an appropriate choice for the Harland Smith Lecture. We know that after thoracoabdominal aneurysm repair, paraplegia is one of the most devastating complications. And underlying this, the reason for Dr. Etz's selection to deliver this lecture today. Dr. Etz's scientific investigations focused on thoracic and thoracoabdominal aortic surgery with a particular emphasis on the spinal cord protection and the mechanisms of spinal cord perfusion during complex repair. He is the one who has pioneered the concept of the modern collateral concept of spinal cord blood flow and has led to experimental and clinical research aimed at preventing paraplegia after extensive segmental artery sacrifice that occurs following thoracoabdominal aneurysm repair. He's been the principal investigator of the PAP-ARTIST trial, which we're awaiting the results of, and that investigated the role of minimally invasive coil artery embolization for the prevention of paraplegia after thoracoabdominal aneurysm repair. And his research combines both translational large animal advances and monitoring of spinal cord oxygenation and obviously the clinical trial that's been underway to improve neurologic outcomes. He's currently the chief of cardiac surgery at the University Heart Center in Rostock, Germany. And prior to that, he served as the director of the aortic surgery and a consultant cardiac surgeon at the Leipzig Heart Center, one of Europe's largest centers, where one of our graduates, Dr. Borger, I think is now the chief. So with that, I would like to welcome Dr. Christian Etz to give the Harland Smith Lecture for 2026.
Yeah, good morning, everybody. It's an honor and a great pleasure to be here. Thank you very much, Dr. Swallow, Dr. Lindsay. I'm trying to condense almost 20 years of research that has been conducted with many contributors in not far from here, starting in Mount Sinai, New York, with Dr. Grieb, to be continued in Leipzig. And so I'll take you back to the roots of this concept that we developed. This is the historical paradigm, and that's why this lecture, I believe, fits perfectly in this anatomical context here. This is the original work of Albert Adamkiewicz. The language is German because Krakow, where he worked at the time, was German territory in 1881. And it's so interesting because all these beautiful images and drawings were the basis of our thinking of spinal cord diffusion for over 120 years. When I started as a young fellow in New York, I remember that Dr. Grieb asked me what would be the topic that you'd like to do research on. And I said, well, and I found that yesterday when walking around here in Toronto, because there was one booth that says, be bold, be sort of visionary. And I found myself in there when I was a young fellow, because I said, my answer to Dr. Grieb was, let's try to solve the problem with spinal cord ischemia and thoracoabdominals. He was just laughing and said, but don't be disappointed if you don't solve it. We were trying that for 70 years now. So the reason why we're trying is obvious. These are the numbers. They have improved a little bit better over the last 2 decades, but we're still with type 2 aneurysms at a devastating incidence of paraplegia after our procedures. So there was much progress, but no definite prevention strategy at this point. And this is how spinal cord looks like when it is ischemic. And this is obviously an animal spinal cord. And this was the paper that started all the, basically the entire endeavor. These are the first 100 patients, one of my first papers from New York. Dr. Grieb's technique was to sacrifice all segmental arteries. And according to the theory of the Adamkiewicz artery, the expected paraplegia rate of this cohort, so 100 consecutive patients, each bar represents the area of sacrificed segmental arteries. So the pink area is the area where the Adamkiewicz was supposed to arise from. So in this cohort, the calculated paraplegia rate should have been almost 60, 70%. Matter of fact, clinically, it was only 2%. So the first fact was that this could not be explained by the artery of Adamkiewicz. We need to understand better how the spinal cord is perfused in our patients. So we went to a lab and we started really with the anatomy. And this is a nice preparation of one of my fellows at the time. You see all the segmental arteries, and they obviously are really significant. So we didn't find any Adamkiewicz at the time. And these are the arteries that we block when we deploy stent grafts. So it's pretty obvious that that for endovascular repair, there is no option of reimplanting segmentals. And that was the strategy that many surgeons worldwide would be using at the time. So next step was to understand there's basically two mechanisms One is aortic cross-clamping, and the other one is segmental artery occlusion. And we have to distinguish between these two mechanisms in order to better understand what we're actually doing. Schematically, this is what it looks like. And so first step was to go in the experimental lab, simulate open TAA repair in a pig, and measure blood flow to the spinal cord. The technique we used for that were fluorescent microspheres, so little ping pong balls about the size of an erythrocyte. They were injected, they get caught in the capillaries, and then we can count them and basically calculate the blood flow to this area. And this is what happens when you place your cross clamp. In the lower spinal cord, the perfusion is basically zero. So since we have to put that cross clamp, there's only two ways of protecting the cord with this technique. One is temperature, the other one is keep the time of cross clamping short. We added later on distal aortic perfusion, but these are basically the three measures that help us with that. That is preventional measures for open repair. So let's look into the basics of spinal cord collateral circulation now. Again, this is just to remind you where we're coming from. And what you see here is an electron microscopic picture of acrylic resin casts that we started basically developing in a large animal model, in a pig model. And this is how that cast looks like when you dissolve all organic tissue around the acrylic resin. You see here the aorta, the renals, and you see this rich collateral network that surrounds the spinal cord and the spinal column. And you see that it's imaginable that there's a lot of potential collaterals that we could hopefully utilize for our purposes. Has been hypothesized previously that there must be this network by other groups. So we were sort of convinced that we would find some answers to our questions by the group of Michael Jacob from the Netherlands. They tried to visualize the collateral network by MRI, and it could only be visualized in a certain number of patients, but not in all of them, because it's very complex and very small. Now I'm coming to the most interesting images, in my opinion. This is from an exhibition that was in New York at the time. The Bodies exhibition, actually an anatomist from Leipzig, von Hagen, who was traveling the world with this exhibition. It was explicitly prohibited to take pictures, but I thought it was for a scientific purpose, so I had to take these pictures. And so smuggled them out, and for the first time, I saw in the human cast that there were segmentals, and there's also this rich collateral network. So we came up with the idea to use that technique, and we made the first cast of a pig. And you see, this is on the first attempt. We had to adjust the pressure in the heart-lung machine to get better details on that later on. But you see, it's very similar, and it seemed to be a great experimental model for our purposes. So we were playing around with that model a little bit. We perfused segmental arteries with different colors to understand how the collateral network would interact in the paraspinal region. So we could identify preformed anatomical collaterals. We could even find what we called a lumbar circle of Willis. This is now the dorsal view. We see here repetitive circles that can distribute blood from one side to the other, and also from the cranial to the caudal portion of the spinal cord. So next step was to further investigate and understand the physiology and the potential changes in this collateral network when we would do our procedures. So we looked into further detail, and actually, when you take these casts, it looks like a sponge a little bit. So when I was a young fellow at Sinai, I took that little piece and I carried up 2 floors from the 28th to the 30th or so in the Sinai building to the electron microscopy guys. And I said, I have something here. Can you make some pictures for me? And then the guy looked at it and said, well, can I vaporize or put gold on it? And that's what they apparently need. It's a present. It's yours. You can do whatever you want with it. A couple of days later, he presented the pictures, and they were really exceptional. Problem was, as a cardiac surgeon or in a cardiac surgeon training, I would not have an idea what I would be seeing there. So I asked the guy, and he said, well, I don't know either. I'm just here to make the pictures. So since I was from Germany and my PhD, I had done in the Max Planck Institute, and Max Planck has a dense network of specialized institutions. They also have one particularly for arteriogenesis and angiogenesis. So I sent these pictures to Germany, and I got a very excited phone call back from the director of the Institution of Angiogenesis in Bad Nauheim. And he said, where did you get these pictures from? That's amazing. What you see here is basically angiogenesis and all the little stigmata of angiogenesis, all the signs. So you see how the sprouting of new arterioles, and this is a network that is in change. So I explained to him what the experiment behind this was, and then we started analyzing these images. And what we could prove is that not only the number of arterioles would increase after segmental artery occlusion, but also the entire architecture of that network. So there was a paralyzation that would basically redirect blood to the areas that had the lowest perfusion at the time after segmental artery occlusion. So my question to the specialist for angiogenesis at the time was, how can we trigger? How can we actually make this process work for our purposes? And he said it's based on shear stress. It's not based on molecular things, it's based on shear stress. So my question was, what is the distance? What is the distance that is most effectively creating these changes? And he said, well, we don't really perfectly know yet. So we started analyzing, and this is now a very crucial figure. You see the random structure in the regular collateral network down here. And then you see how that changes with segmental artery occlusion. And the architectures or the degree of paralyzation is most pronounced in what we now call the watershed area in the middle of the spinal cord. And the reason for that is obvious. The body tries to transport more blood to the areas that are further away from the inflow from the cranial, so the subclavian artery and the caudal inflow. So at this point, everything made sense. And the next step, obviously, was to not only understand the anatomy, but also the physiology. This is a video, but it's very old. Maybe that's why it doesn't run properly. So actually, we ran out of microspheres. So the next step would have been to do the microsphere experiments in this setting. But we ran out of microspheres, and the company could not deliver for 6 or 8 weeks. So I came up with the idea to just put a pressure catheter in one of these segmental arteries and measure the pressure over time to understand what is the time course of pressure that the spinal cord sees. And it was obvious that these arteries are very small. You need a very small catheter. And I mentioned that last night at dinner, that before pronouncing or suggesting that technique to my mentor at the time, Dr. Grieb, had to make sure that I was capable of putting that catheter in. So I practiced this in the lab. It worked well. And this is what we found with this pressure catheter. So at baseline, all segmentals are open. See here on the left. When we start clamping or finish clamping, the spinal cord blood pressure goes all the way down to 20% of the baseline, stays there for about 5 to 8 hours, and then it starts coming up by itself. 60% after 48 and 5 days after segmental artery occlusion. The pressure that the spinal cord sees has almost entirely recovered. So that mechanism, that was really the first and most really breathtaking thing to see. And obviously, we wanted to get more images on that. And this is, I haven't shown that very often. This is an angiogram of a pig on day 5 after a total segmental artery occlusion. And what we can see here, that there's retrograde filling of the intercostals. So proving that the collateral network has already taken over. You can even see the filling of the anterior spinal artery. And that is 5 days after segmental artery occlusion. So we learned that we can actually use the idea of spinal cord perfusion pressure clinically and then tried to put that catheter into patients. These were the first patients at Mount Sinai. One case of paraplegia, and our catheter could have indicated that this patient will have a problem postoperatively, only that we didn't know at the time what the normal values would be. So, and it also indicated that in humans, this process of recovery seems to take place as well, is a similar way as in pigs, just it seemed to be a little bit slower. So we went back to the database over a 16-year period of time. I analyzed 800 thoracoabdominals with a paraplegia rate of 3.7%. MEP and SSEP measurements were the standard protocol. And for this retrospective study, we were choosing only patients that had intact MEP and SSEP measurements at the end of the procedure. And 10 cases developed delayed onset paraplegia that you could not have detected with MEP and SSEP intraoperatively. So these are the crucial cases that we have no warning signs intraoperatively. And then we matched these with controls, and the idea was to identify differences in these two cohorts. And initially, I was extraordinarily disappointed because there didn't seem to be any differences. So we could not identify what is different between the ones that developed delayed paraplegia and those that didn't. And then I came up with the idea that juvenile pigs cannot be compared with elderly patients. They have a lot of comorbidities. One of them is arterial hypertension. So we looked into the mean arterial pressure in both groups. And again, another disappointment, they were similar. Then we looked into the relative mean arterial pressure postoperatively as compared to their personal pressure. So patients with hypertension got as their baseline their regular blood pressure, which is higher than in the regular patients. And that's where it turned out to become highly significant. This is now in all the guidelines worldwide that we have to adjust the blood pressure of the patients on the ICU postoperatively to the patient's personal baseline, not regularly to anything that we've set up in the standard protocol like 90 or something. That makes sense because the collateral network needs sort of a working pressure. Otherwise, collaterals cannot be effectively protecting. So that was a very important thing that we came up from a retrospective study. And this is courtesy of Joe Bavara. You probably all know him from formerly from Philadelphia. When I presented this data, he came up with his data and said, this is exactly what we've seen, but no one of us could explain. We have seen so many delayed paraplegia cases, and it seems to be now explainable with your theory. So a clinical implication of all that was to try to sort of modify the pressure drop in this collateral network postoperatively, or maybe even preoperatively, so to get a more robust system before we do the actual repair. So next experiment, that's what you've seen before. On the left side is the pressure curve, on the right side the clinical result. In pigs without a proper ICU and everything, paraplegia rate was about 40%. And if we now use the knowledge that we got from the Max Planck people, that we have to create pressure differences, so shear stress, we came up with the idea to stage the segmental artery occlusion. So we occluded only half of them. And then a couple of days later, the rest. When you see here what happens, pressure drop is not that dramatical anymore. All the pigs can walk. That was the first pig without segmental arteries. And obviously, when you see that for the first time, you don't believe it. You think it's impossible. And then you do another one, and it worked. Do an autopsy, all segmental arteries are occluded. So we saw that this technique would actually work. To confirm the data, we went back to the clinical database, and I found 35 patients over the 16 years period that had, not intentional, but by accident, a stage repair. They came with an abdominal, and later on, they had a thoracic. And interestingly, no one had yet figured that out, because no one looked at the data on that from that angle, from that perspective. But the paraplegia rate in the stage ones was 0. So that was another proof that a stage procedure may be protective, and that probably the same thing applies to the chronic type B dissections, where segmentals obviously in many cases are previously have been occluded. So then we went on, we published that. There were other groups from Stéphane Hollande, endovascular guy from the time in Lille, now he's in Paris. And the concept of staging the repair became more popular. A tenfold reduction in endovascular repair in this group. So we thought, okay, we need to find a strategy that is minimally invasive to prime the collateral network. And priming is important. It's not preconditioning, because preconditioning is a word that is reserved for angiogenesis. And what we wanted to create is arteriogenesis. It's different. So we called it priming. And I happened to run into a neurosurgeon, and I explained to him what my problem was, that I needed to occlude these small arteries. And it was actually in the steam room of Mount Sinai recreational thing, sitting with this for weeks with him there every evening. And then after a while, we started talking for the first time, and then it turned out he's a neurosurgeon. I explained to him what I was doing, and he said, "Why don't you use coils?" And I said, "Well, I thought use them only for barrier aneurysms." And he said, "Yeah, but we lose them so often. They always get stuck in some small arteries, and they occlude after that. That's a problem for us. But that's exactly what you intend to do." So we started using the coils, and again, we could see when we occlude the segmental arteries, there's zero paraplegia after coil embolization. We could prove that in the animal model histologically, and it seemed to be a good idea, and it seemed to be safe. So then I moved back to Germany, to Leipzig, and Thilo Kölbel from Hamburg called me and said, "You have proven everything experimentally. Why don't you do that in humans?" And I came to Hamburg, and we did the first human cases, one open and one endovascular. It got published. There was a lot of comments on this new technique. But the technique itself was potentially dangerous, because we did something to the patient's circulation that in the session of the coil embolization had no direct therapeutical cause. It was preparation. So if anything would go wrong, it would be a disaster. In other words, we needed, after a couple of pilots, we needed to design a clinical trial. That was one of the first we did in Leipzig. You see here is a chronic type B. This is how the coil embolization was done at the time. Since cardiac surgeons are not familiar with all the endovascular equipment, we asked our pediatric cardiologist who's familiar with MAPCA coiling to do that for us. And he said, it's great, we'll do that. And we started the first patients. And then we published the first results. So preliminary, and I have to admit that I didn't feel very comfortable because we still didn't know about the risks, but you have to start at some point. And I was very glad to see that there's 0 spinal cord ischemia in the first almost 50 patients. Minor complications were back pain. And that was also very logical because if you occlude the segmentals, you get less perfusion to the paraspinal muscles. That's where the collateral network sits in. And that can create pain. So initially, when we started doing this, we said, okay, we will stop the procedure if the patient feels any pain. We did that, and this seemed to be a good safety measure. So this is the evolution of all that I've demonstrated now. We started with the anatomy, NIH funded, and then we came up with other large animal experiments, chronic experiments. We developed technique, found the proper technique to that. And then we got funding and we started the trial because what we called minimally invasive stage segmental artery coil embolization seemed to be promising, but we have no level A evidence yet. And then the German NIH equivalent, the German Research Foundation, was interested in funding it, and also the European Research Commission. So we got double funding for that trial. And at the time, it was the largest publicly funded research trial, randomized controlled trial in aortic surgery worldwide with over 10 million euros. The plan was 5-year duration, 500 participants, 31 recruiting sites in 9 countries. And unfortunately, then the corona pandemic hit. But the concept was, I thought, very convincing. So for the first time, we would prospectively collect contemporary real-world data on the incidence of spinal cord ischemia and open-end endovascular. We could compare staged with this conventional approach. And also, we would get better real-world data on the actual incidence of endoleaks. That was something that the FDA was interested in at the time. The problem was that this concept of staging was so convincing that in the control arm, most centers would start staging without coil embolization. So we were just 2 weeks ago sitting with the data, and it's extraordinarily complicated because almost 80% of the patients in the control arm have been staged. So that is, and analyzing the data will be very complicated, but I'm happy to see that the general principle of staging, and that was the initial thing, right? The minimally invasive coil embolization technique was just a tool to get there. So if it's possible to do that in a staged fashion with stent grafts, it's also fine with me, obviously, if it helps. So these are the centers that were contributing, many in Germany. And so we went from this high incidence to analyze anatomy and get a better idea of the actual clinically relevant things. We identified the clinical mechanism. We've also identified the pathophysiology behind it, confirmed everything in the experimental lab. So it's an iterative process going back from bench to bedside and back to bench. Developed the technical tool, and now we are just about to finish the clinical trial. I think that's a very nice proof that integrative translational research is crucial to take innovative strategies from bench to bedside and improve clinical practice in open endovascular. And yes, there's many questions, so thank you very much.
That was pretty tour de force about from the sauna to the PEP artist trial. Seems like a long way to go. Are there questions from the audience that are present? No?
Thanks so much, Christian. That was absolutely amazing and great for the trainees to hear like a concept that actually started in the lab that has really profound clinical implications and change the way we practice thoracoabdominal open and endovascular surgery. My question's around conducting a randomized trial in aortic surgery. This is not an easy thing to do, and particularly when the patients are very heterogeneous, it's very dependent on surgical technique. We're trying it here in type A dissection, hemiarch versus frozen elephant trunk. It's not easy to randomize patients.
Yeah.
Can you just go into that a little bit, just the process of designing it, the centers you chose to do the trial, how you're going to analyze data from open, endo, extent, you know, the various rates of paraplegia, and elaborate.
Yeah, it's very, very important and very good question, Maral. That well, you start out with a good concept and good idea. So far, everything seems to be easy. Convince people of the funding agencies to support you. That's what we all did successfully. And then the problem you have is you deal with people that are used to do pharmaceutical trials. And then it's most of the time pill A versus pill B. And it doesn't matter who delivers the pill to the patient. And in our case, it's a very complex pill B because it depends on so many factors. Depends on, in the first place, on the surgeon and the place and the postoperative care and the entire team, the nurses, how everything works. So you have to streamline the protocols. You have to find that one core protocol that all the centers that you would like to participate would agree to adhere on. So you have to make sure that you consider institutional protocols and find the best common grounds that everything could be done in different places. Very complicated. Most trials that are not successful were seized because of they cannot recruit, basically. So when we started all this, we had little experience. We had experienced people to support us, but they came from the regular epidemiology places. And you know, the Leipzig is a big place for clinical research, basically. So we have professional people there, but they also understood that this was an endeavor that was different than all the other trials that they had been doing before. So it turned out that we started with very restricted inclusion criteria. And initially, we only wanted to do type 2 aneurysms because we thought that the differences should be most pronounced with the most high-risk patients. And it turned out the definition of a type 2 is not perfectly common between all centers that were contributing. So most endovascular people would define the extension of the aneurysm by the coverage area, where surgeons, open surgery, would say this is where the aneurysm starts and this is where it ends, and it doesn't matter where I do my anastomosis, right? So there's so many little things, and it was really painful, the entire process. Then you get into interactions with very experienced people that were contributing to the trial or were willing to contribute, but then they have their own ideas of why don't you include also type 1s? They have a high incidence as well, and type 3. And so you're constantly trying to find compromises that all have the goal that the quality of the data is high and that you get enough patients. And if you then get hit by a pandemic, that is really, that was really terrible, I have to say that. It's all, most of them are elective cases. We excluded the emergency cases because we couldn't randomize. So that's only by the planning part. Then it comes to the patients. It went to the media beforehand. The European Research Foundation is supporting that. They want you to publish things. So if patients that come for consent, they oftentimes said, we don't want to be randomized. We want the new technique. So I had to convince many heads of many centers that we cannot proceed only with the staged, with the coil embolization because it's not yet proven to be safe. Not all of them would understand that, and would many of them also in Germany just went ahead and did it. So that was another problem. So we had patients that would not be in the trial, but they would be coil embolized. And then they found the compromise, say, okay, if we use stents and not the coils, then we don't add anything new, and we can say we started repairing and then we've proceeded with the repair in the next 3 months. That's how the control group, developed to the staging. So initially, we had a very strict protocol that said no staging in the control group, and then turned out none of the expert centers would be interested in contributing to the trial anymore. So we had to change into institutional protocol. So many obstacles, many pitfalls, and it's very hard. So if you plan on things like that, you should get an expert, not on the side of on the epidemiologist, but on the clinicians that have done something like that to sort of support you. I think that's the most important thing. Long answer, but very complex stuff.
Great answer. Yeah, very complicated for sure, because the equipoise will change, and you believe that this technique, works and helps record ischemia, but then you have to subject, patients to randomization.
Yeah. Then you have patients in there that sign consent and then they withdraw. In a very strict RCT, they count as failures. And you have patients that commit suicide, patients that get involved in some accidents and stuff like that. So it's very difficult. And if you have very strict epidemiologists, they only see their RCT rules. And if they don't adhere to the RCT rules, then they refuse to do the analysis and things like that. It's very difficult. In that phase we are right now.
Mark? Yeah, go ahead.
Thanks. Congratulations on such incredible work. It's astonishing. So this technique is not easy. You can spend a lot of time there, a lot of fluoro, and feeling like you're not getting very far. Do you have a sense of which are the critical areas that you should target first and spend the maximum amount of time trying to embolize before moving on to others? And do you have a technique of kind of do a pair, miss a pair, do a pair, miss a pair, that kind of thing?
Right. That was actually what you're mentioning here is what I thought would be the best idea. And in the next talk, in about an hour or two in the symposium, I will go much deeper in that topic. My initial idea was do alternating. So occlude one pair, leave one open, occlude one. And then don't want to spoil the next talk, but it experimentally, let's say, was a surprising result. What we also thought that's my belief. Of course, if the patient has no previous coronary bypass surgery where the thoracic artery was used for a Lima bypass, then you have an instant anatomical backup system via the memories to the intercostals. So to coil embolize anything that has this collateral, so down the entire intercostals, may not be that important. It may be much more important to start coil embolizing the lumbars because there's no such direct backup system. And it seemed to also be this, what we call then the watershed area, where we've seen in the middle of the cord about T12, L1, L2. That seems also to be the most vulnerable area. So that is what I think we started then doing. As a matter of fact, it was surprising when I saw that in the OR at Mount Sinai in the clinical OR, and that's why all this came up, that Dr. Grebe would basically take the entire aneurysm, dissect it, and then start from the outside to clip all the segmentals in each and every case. And that worked. That's why I was so convinced that the entire thing would work, that we could actually do that. And in particular, when we do it in a staged fashion. So probably it's not that important way to start, and actually just that to start and occlude the most important ones. Well, also it's interesting when you do open surgery, you see the back bleeders, right? And the back bleeders, that was common sense in the community of open experts to reimplant the back bleeders. But if you now see that concept, that is not necessarily the truth, because the back bleeders have obviously an instant collateralization. Otherwise, they wouldn't bleed back. So if you decide for reimplantation open repair, is probably more important to reimplant those that do not bleed back.
Actually, I had the same question as Dr. Wheatcroft, but I'll ask another one. Do you think there's any biological entities like, VEGF or any factors that we can give our patients in addition or along with coil embolization that can help augment or speed up the process?
Yeah, very good idea. That was one of my first ideas I presented to Dr. Grebe. And he said, no pharmaceuticals, we are surgeons. So I could not follow that path, but I think it's a good idea to look into things that you just mentioned to support that process. Absolutely. It also is a good idea, and we started that. It's just with too many good ideas and not enough people that work with us. So you all invited to at some point if you're interested to come over, because another thing is that we can know how much collateral, let's say, volume is there that can host the collateral system. So it's frailty and sarcopenia are the things that come in mind there, right? So we started a project where we measured the paraspinal muscle density, figure out whether this could be a high-risk patient or not. At the time, it was manual thing. We had to do this manually, and that's why it required lots of PhD students and things like that. Today, probably would be AI that could help us with that. But there's a lot of things that that I believe would be helpful. Yeah.
Well, maybe I can ask. So, since you stopped including arteries on the basis of reported back pain, how do you make sure every patient across all centers are consistently treated? And could that be an inconsistent effect in the result?
Absolutely. So to avoid issues with the actual adherence to the protocol, we created a core lab in Scandinavia with experts to, in a blinded fashion, look at all the CAT scans pre and post-operatively. Ideas seem to be great. Problem is, if the center doesn't submit any CAT scan, then you don't get any analysis. So that's something that we are right now into, to not only check for the proper let's say success of the actual aneurysm treatment. So there's a lot of discussion about endoleaks. Is that an endoleak? Is that no endoleak? Aneurysm growth. Is the sac 3 millimeters? Now the community or the vascular society decided that it's only dramatic growth if it's 1 centimeter. So everything has to be changed. The criteria that we were initially using have changed over time during the trial. Very, very complicated. So we do that with a endpoint committee where different experts try to be neutral and come to the best conclusions. But it's a very valid point.
Very much. Actually, my question is an extension of Dr. Zunian's question. So it appears it's quite difficult to find the sweet spot, so to speak, where you induce some sort of ischemic insult such that there is a protective effect, but equally you don't want to push it so far so that you actually induce cord ischemia. And of course, in your acrylic resins, the animals, they all had preserved hypogastric internal iliacs and Palladians. But my question really, as I say, is an extension of Dr. Zunian's. How does one translate that into a clinical trial where unfortunately our patients aren't as healthy as the
Planners, only way. Yeah.
Quite.
So
how did you adapt for that and control for that?
Yeah, it's only the core lab is supposed to give us the true information on the actual patient's anatomy and all these things. And so all we can do at the end is perfectly describe the cohort. And then whoever reads the paper can draw his or her own conclusions. That's probably the only thing that we decide upon doing. There will be lots of supplemental pieces and parts and pieces of that paper monitoring the process. And it's important to understand that we do not want to trigger ischemia with we prime the collateral, the spinal cord. It's not supposed to see anything at the time of recording or afterwards. So for that, we could use monitoring and show that also in the next talk that infrared spectroscopy may be a tool to do that. And we did experimental by the Doppler flow measurements in the animals to monitor the processes that we trigger with that procedure. And I remember that Morel and I think we had discussions about long time ago. I remember that we're talking about the iliacs and that went also into clinical practice, that people don't use a bigger sheath and they try to have the exposure time short in order to not compromise the caudal inflow. In open, the analog is distal aortic perfusion, right? Time's up, apparently.
For your presentation, is there a critical number of intercostal arteries or lumbar arteries that you can embolize per session without causing paraplegia?
Excellent question. That was the most crucial question before we started the trial. Everyone asked that question. And the answer is, we don't know. We only know from the clinical experience at Mount Sinai that the way we did it there, Dr. Grieb started doing it. In each and every patient, every segmental was occluded, and after aneurysm resection and repair, there was no reimplantation whatsoever. We know from other groups that reimplantation initially may be successful, but most of the reimplanted segmentals will occlude with time. There's from some French and I think Belgian groups, some evidence in Asian, Japanese groups. So safe is relative in that. What we did in the human study, we asked the centers for at least a 1 to 3 week interval between the coil sessions. And that was the centers were very adherent to that. So they started sometimes in the first patient with 3 sessions over a period of a month or 2. I also believe that comorbidities like diabetes may compromise the process, and that we probably will learn with time that some subgroup of patients need specific intervals. And then maybe what the colleague behind you suggested that also there's some pharmaceutical amendments or things that we can trigger or support the process.
One more question in the back.
The mic is not working.
I'll repeat it.
Better.
Excellent presentation. I was curious to know what would your opinion be on the use of intraoperative neuromonitoring to monitor spinal cord injury during these procedures?
Yeah, excellent idea. A lot of effort. It was standard protocol when I was working in New York. We did MEP and SSCP in all patients in open repair. When I came to Leipzig, there was zero neuromonitoring. Leipzig is university center, but it's owned by private companies, so it was just too expensive and too. There was just lots of critics about the time that would take and everything. And after we found out that many of the paraplegia cases would occur delayed postoperatively, we even used the MEPs with the magnets, so we could use it in the ICU afterwards for a while. So I think it's great. If it's available, one should do it. I hope that we may not need it in the future when we succeed with these endeavors.
Thank you again for this amazing talk. So my question is that one of your earliest observations was clinical in the Mount Sinai cohort, looking at early versus delayed paraplegia, and that it was the delayed cohort and the ones that could be rescued versus not that made the map observation. I was wondering if you can explain to us what's happening in the collateral network between the ones that we see that wake up densely paraplegic versus the ones who have this late.
I would like to go back to that one picture, maybe this here I can explain. The crucial time are the first 18 hours. This is when the processes are triggered and started, but they're not yet effective. So this is where the nadir of spinal cord perfusion occurs in all patients. To bridge that critical period in time, the only thing we can do is make sure that the pressure, the systemic pressure, is high enough so that the not yet efficient polarization or the network can still provide enough perfusion to the cord. And that was the main thing. So initially we had adjusted, and I'm sure Perose remembers when we did that in Leipzig, they would all get mean aortic pressure, arterial pressure of 90. That was already high. Many surgeons wouldn't like the patient to have such high pressures after thoracoabdominal repair. But then we started to look into what is the initial pressure of the patient when he's anesthetized. And we saw that many patients have very high pressures, but they are used to high pressures. And I think the only way to overcome that, if you do not have a chance to prime the collateral work previously, this is the only thing you can do. And then there was one other picture where I showed you theoretically the pressure, the spinal cord perfusion pressure, which is an artificial acronym that we created to understand it better, is the pressure that actually comes from the arterial inflow, and it is counteracted by the pressure in the dural sac, so the CSF pressure. And the CSF pressure we saw in many of the patients that correlates quite well with the central venous pressure. And that also makes sense from an anatomical point of view, because the venous system reaches out to and sort of communicates with the dural sac. So volume therapy is very critical for these patients. If you overload them with too much volume, you get very high central venous pressures. You will thereby increase your CSF pressure, and that counteracts the spinal cord. That's why Dr. Grebe was a big believer in epinephrine and norepinephrine for these patients, and not so much in volume, although they need a lot of volume. So it has to be very balanced. Post-operative period is very critical. And CSF pressure, Dr. Hounschild, as you say here, Hounschild, is we'll talk on our experiments on CSF pressure in a moment, and that is also a very interesting topic because it's not yet clear. The endovascular community is not that convinced that it's a good idea, but we probably can discuss that in this.
So I think that we're unfortunately at time. There are a few last questions, but what I'll do is I'll just say what the questions were, so that we can discuss them later. So what's the success rate in including intercostals and lumbars in atherosclerotic and aneurysm patients, and how arteries are occluded per session? So Dr. David wants to know that, and he says, I'll tell him that the series was published in the JVS from Toronto, and it's about 3.5 per patient. And Dr. Failings, who's very interested in spinal cord ischemia because he's a spinal surgeon, wants to know about neuroprotective drugs and Reluzol. I don't know if you've heard of Reluzol. We'll talk about that later. And then should more importance be on intraoperative paraspinal blood flow measurements using NIRS? And I know use NIRS intraoperatively.
We started doing this very early.
Right.
And in the history of near-infrared spectroscopy, people tried to directly monitor the spinal cord. That's impossible because light cannot penetrate the bone. So the idea was at the time, and we started doing that in China already, to put it paraspinous, the patches, and measure the collateral network. And that's also in the next talk, because we can show you how nicely oxygenation of the spinal cord correlates with oxygenation in the collateral network, which we can measure. So I believe that near-infrared spectroscopy monitoring is a great tool. Yeah.
The last question was spinal cord perfusion monitored between embolization sessions to confirm arteriogenesis was actually occurring?
In patients, that is would be a very, very invasive measure, because you would have to stick at least laser Doppler flow needles in there, so that we didn't do that. There's hyperspectral imaging that has been attempted by Daniela Branzan in Leipzig. It's sort of similar to the near-infrared spectroscopy. Would be very nice to have data on that, but we do not yet have it. Maybe there are some markers. I know that your group is working on that. That could help us in the future with that. CSF is a medium, sort of, in CSF. We started doing lactate measurements and stuff like that. Because whenever you develop these measures, you have to already think how you can use it clinically. If it takes lab analyses that take hours or days, it's not useful. So bedside tests.
Right. Hey, listen, thank you very much. I appreciate everybody attending, and thank you very much, Dr. Etz, for a very vigorous talk and lots of good questions. For those who are interested, we are continuing over at Toronto General at starting at 9 o'clock on the 12th floor in the Eaton Wing. People can either sign on electronically or come to the talks, and we'll look forward to seeing you all. And thank you again very much.
Thank you very much.